So welcome to Decoding DX. We have a session today on fever and tachycardia, and we have two discussants with us. So I'll let the two of them introduce themselves.
My name is Dylan McKee. I am a third-year medical student, and this is my first time on Decoding DX. I do like internal medicine, but right now I am interested in emergency medicine.
So my name is Abebe Abebe. I'm one of the internal medicine faculty in the Department of Medicine. I'm one of the core faculty as well in the residency program and involved in multiple medical educational activities, including this one. And I'm glad to be here.
All right. And thank you both for being here. So we'll just go ahead and jump right in. So we have a 32-year-old male with no significant past medical history who was presented to the ED with intermittent fevers and tachycardia per his smartwatch. So his smartwatch alerted him and said that his heart rate had been elevated. Just kind of with that very minimal information, before even walking in the door and meeting the patient, would Dylan first, and then Dr. Abebe can kind of add on, would you guys just kind of give us a quick first few thoughts, things that are, main categories of things you might want to be thinking about, and or any life-threatening things that you want to be sure to kind of knock out right away, just in case that's what's going on?
Yeah, okay, for me, I guess before I would kind of start thinking about my differential, I would like to know a little bit more about his history, like how long has this fever been going on? Has this kind of been a pattern, or is this, just started all of a sudden today? But when I think of a fever and tachycardia, things that come to mind are all of your infectious causes, underlying malignancy, but for this guy, if it's just happening all of a sudden, I don't really think of that. And then certain autoimmune diseases, maybe he ingested a drug that didn't sit well with him. Sometimes you get tachycardic and febrile after that. So there are just some things that come to my head at the start.
I think that's a very nice start. So what is going to be intriguing is this is a young patient who doesn't have medical history, whose differential diagnosis of fever is going to be completely different for a patient who is elderly, who has multiple comorbidities. When I look at fevers in general, I kind of think of in terms of whether this is an infection or non-infection. Obviously, always now from 1 to 5, I always think of infection, and then if I can go further, then I always look at the non-infectious causes. As Dylan has described, I'll categorize it as malignancy. Primarily, we're thinking of leukemia, lymphomas as a B symptom, although there are some malignancies that can still present with fever, either as a presentation or a complication. And endocrine causes like thyrotoxicosis or hyperthyroidism come into into picture. And last but not least would be iatrogenic, like if you are someone who's taking medications that probably have the potential to cause fever. Going back to the fever of infectious etiologies, I would categorize it as in immune and non-immune host. I mean, like I said, this is my way of thinking. And if someone is immunocompetent and or immunocompromised, my thought would be different. When I see fever and tachycardia simultaneously, SIRS comes into picture, meaning systemic inflammatory response syndrome, because this is 2 out of 4 that you would need to categorize. So I'll be having a heightened sense of concern in a young patient with fever and tachycardia, not having background illness. So I'll be thinking of an infectious still, but I'll think of infection, and I'll be having sepsis as at the back of my mind, and I'm sure we'll talk more about this.
All right, awesome. Thank you so much for that great starting point. So a little bit more history, like Dylan was kind of asking for. So starting with kind of the history about the fevers. So he's been having intermittent fevers almost nightly for 3 weeks now. He said that they usually appear in the evening, and then they spike to as high as 101 or so. And there are associated body aches. And then the fevers are generally gone by mid-morning-ish. He manages them with acetaminophen and ibuprofen. That usually does a good job of knocking down the fever and taking care of some of those symptoms. He does note that he had a cough and sore throat a few weeks ago that self-resolved, but other than just a little bit of a residual cough from that, he doesn't have any other localizing infectious symptoms. He said he did see his PCP for this a couple of weeks ago and got what he referred to as some basic lab work done. And he said all of that was unrevealing. And all of this kind of fever picture, again, has been going on for about 3 weeks. In terms of the tachycardia, that first started about 5 days ago. Like I said, kind of at the beginning, his smartwatch alerted him and said that he was tachycardic. He said his heart rates had been like over 100s easily for those last 5 days, persistently over 120. He said that he, once we asked, he said, yeah, I do kind of have just kind of this uncomfortable, palpitations in his chest, but no chest pain per se. The tachycardia persists regardless of what's happening with the fever. So it's not a relationship of like when the fever happens, the tachycardia is there. The tachycardia is just always there. He has missed work for the past couple of days just because of this constellation of symptoms and the overall discomfort and fatigue that he's been having. In terms of past history, doesn't have any significant history, no past surgeries, no hospitalizations. He doesn't take any prescription or over-the-counter medications. That Tylenol and ibuprofen as needed for the fever are really the only meds he takes. From a social standpoint, he doesn't drink alcohol, doesn't use any illicit substances, doesn't use caffeine. He's a never smoker. He is married and he works in an office setting. So Dylan, we'll start with you. How does this history kind of help or affect your differential? And then if there's any other like information that you want to know, I can also kind of add it on there.
Right. So having the pretty much negative history, family history, social history, past medical history, all that stuff, makes me kind of, Dr. Abebe hit on things like iatrogenic, maybe he's taking weird medication. That probably isn't going to be the case here. When I think of this nightly fever that goes away during the day, that leads me towards things such as those B cell symptoms you think about with certain malignancies. It also makes me think of certain infections that you see where the fever happens in a sort of a pattern, like you'll see with certain types of malaria and other bugs like that.
Because of COVID, not a whole lot of travel over the last year. They've been really diligent about staying at home. But before that, they did do a decent amount of travel to Europe and to East Asia, but has not traveled in the last year plus. And then someone asked, are there any sick contacts? No sick contacts, hasn't been around anyone with these symptoms, no COVID exposures. And he actually got a COVID test when he saw his PCP a couple of weeks ago, just because of the fatigue and everything, the fevers and everything. And the COVID test was negative. Those are all great questions. Dr. Abebe, anything to add?
Intriguing is he has had this fever for 3 weeks. So it's more of subacute / chronic. So I would not be concerned about gram-negative infections, although it's always a possibility, because usually the patients would be quite sick. And the same holds true like major infections like meningitis or bacterial pneumonia. So, the fact that it's been there for 3 weeks, if you're looking from a perspective of infection, you have to think of a subacute infection. It could be a viral infection. It could be more of, I would call subacute bacterial infections, like maybe tuberculosis or brucellosis, or things that are not life-threatening immediately, although the patient is young and immunocompetent, from what I understand, based on his current history. I would also agree with Dylan that we have to think of conditions like malignancy on the back burner. I'd rather have it in the back of my mind. Also make sure that he doesn't have B symptoms like sweating, weight loss, which will be very helpful.
All right, awesome. So kind of moving on to some of our objective data. So his temperature right now, it is currently the evening. His temperature is 100.8. His heart rate is 131, blood pressure 126/76, respiratory rate of 15, and he's satting 99% on room air. On physical exam, he's diaphoretic, just kind of sweaty. He said that's normal for him when he's having the fevers. And he's not in acute distress, but he just looks, a little bit ill appearing. For HEENT, he has somewhat dry mucous membranes. He has slight fullness and tenderness when palpating his anterior neck, and he has no lymphadenopathy that you're able to appreciate. From a cardiac standpoint, he is tachycardic. He has a regular rhythm. He does not have any murmurs, rubs, or gallops. From a pulmonary standpoint, lung sounds are clear to auscultation bilaterally. From a neuro standpoint, he's alert and oriented times 4, no gross neuro deficits, and the rest of his exam is otherwise normal, unremarkable. So with all of that information, first I'm going to kind of, we usually kind of take a little bit of a kind of pause at this point to summarize and do a problem representation. So Dylan, would you mind giving us kind of a 1 to 2 brief, just sentence summary problem representation for us?
So yeah, we had a 32-year-old male today who presented to the emergency department with a 3-week history of intermittent off and on fevers and tachycardia, which he's measured through his smartwatch. This has been going on for about 3 weeks after he had a sore throat and a cough. The cough is still a little bit residual, and he has no past medical history and takes no medications.
All right, awesome. I think you really nailed all the key points there. So great job. And then, so kind of from here, what additional labs, imaging, other workup would you like to get next for this patient? Dylan, I'll have you kind of answer that first.
Yeah, okay. So I guess I don't know how basic of labs here. I'm assuming they just did a CMP and a CBC. So I would want to get either a CRP or an ESR just to kind of get a general idea of the inflammation going on in the body. I would also like to get a TSH and T4 level. We kind of brought up the endocrine earlier, and then also having the anterior neck fullness kind of makes me want to look in that direction a little bit more.
All right, awesome. Dr. Abebe, any additional workup you'd like to do at this time?
I think to comment on general for a young, healthy patient, there is paucity of physical findings, which would help you, delineate, or localize the source of infection. The only thing that was there was cough, which was not that localizing, and you would think, you would have some pulmonary exam, maybe a sinus or oral exam, like maybe tonsils, and you were not able to see that. If I have a patient like this, I would definitely get some blood cultures, 2 sets of blood cultures. I would add a urinalysis and a chest X-ray. So basically kind of looking at the most common causes of infection, although, like I've said earlier, this his presentation is more subacute. I don't want to go further. And what I was impressed also was that, you didn't talk about musculoskeletal, but I'm assuming that's normal. Another cause of fever is going to be rheumatologic condition. And the other important thing is there is no rash that you described. So there are conditions that can present with rash. So he doesn't have all that. So right now we are in this amorphous state where we don't have good direction, and maybe basic labs and the test that we kind of requested would help. So I would make sure that rheumatologic conditions are added to the differential as a broad. And I agree, maybe CRP, ESR are kind of just a general understanding, and they don't help you localize, but they would certainly help you if there is an ongoing inflammatory condition, but does not differentiate any of the differential diagnoses that we talked about. Maybe endocrine may not be, but rheumatologic, infectious, and malignancies can cause ESR elevation in CRP.
Kind of moving on, getting a little more information with the labs. So for the CBC, white count was slightly elevated at 13.1 with a normal differential. Hemoglobin was low at 12.6, and CBC was otherwise within normal limits. CMP, I won't read off the values, but it was completely within normal limits as well. Thyroid function test showed TSH low at 0.01, free T3 elevated at 5.1, and free T4 elevated at 1.8. And then other labs that all came back normal. So procalcitonin was in normal limits, troponin was normal, BNP was normal, UA was non-concerning for infection, lipase was normal, and the repeated COVID test, which was again negative. Blood cultures were drawn and are pending, and ESR, CRP are both pending as well. An EKG was obtained and showed that he was in sinus tachycardia. There was no evidence of ischemia or other abnormalities. And the chest x-ray was normal, no acute cardiopulmonary abnormalities. Dylan, I will have you kind of start with what does this additional information kind of tell us in combination with the H&P, and can we give a diagnosis based on all of this, or kind of what terminology might you use to describe it?
Right. Okay. Just so I'm clear, I want to make sure I got all those labs right. Was there anything that was not within normal limits besides the white count and the thyroid levels?
Those were it. The hemoglobin was a little bit low, but otherwise normal limits.
Right. Okay. And at this point, just to answer your last question first, I don't think we can put a diagnosis yet. I do think that we can at least say he has hyperthyroidism. And I think we need to do a workup to see what the exact cause of that is. So at this point, I don't know if you'd go straight to an ultrasound or if you would do a radioactive iodine uptake. I'd need to look at the algorithm for how that works for when you have low TSH, but I know you'd want to work that out further.
Mm-hmm.
I think although this patient is young, when I see what I see now, he's a patient with what Dylan has described as a state of hyperthyroidism. We don't know if this is Graves' disease and so forth, but at least there aren't other signs to suggest that yet. But we would have to be very careful and assess whether he's at risk of decompensating. In a patient with hyperthyroidism, we have to be very careful and try to do what we call a Burke-Witowski score, which is something that I would also be comforted by the fact that at least his pressures, apart from his heart rate, has been stable.
All right, awesome. We kind of mentioned that he is in a hyperthyroid state, but can't necessarily, say what the exact etiology of that is. So Dylan, I'll have you kind of go first, and then Dr. Abebe, what would you guys like to do next in order to actually kind of approach that question of what's causing this hyperthyroidism, and how do we kind of give a diagnosis to it?
Yeah, I guess I can go here. I kind of mentioned it earlier. I don't know exactly what the workup would be. I know we'd want to get imaging to see if we're looking at a diffuse thyroid issue or if it's more of something we're looking at a specific nodule. So I know we'd want to do an ultrasound. I don't know if we would do an iodine uptake test, but I'll defer to Dr. Abebe on that.
Okay, awesome. And Dr. Abebe, I'll kind of add to the question too of would you mind giving us a brief overview of the couple different kind of large categories or buckets we can put causes of hyperthyroidism into?
So when you have hyperthyroidism, you want to know whether this is TSH dependent or non-TSH dependent. So if this is purely driven by an elevation in the TSH, or if the TSH is low, as you can see, the TSH is low, and which would be expected in hyperthyroid patients. And you would think of conditions like thyroiditis, where there is inflammation of the organ itself, and you will have an inflamed thyroid that would actually be tender on exam, and I'm sure you probably did the exam, but it sounded like you said he had some slight tenderness, which could be one of the reasons. The other we talked about was Graves' disease, where there will be an elevation in thyroid antibody, or it could be because of nodular goiter, meaning having multiple nodule or like a small toxic nodule. So you can have one nodule, or you can have some multinodular goiter, if you will. And the other one would be, could it be iatrogenic? We don't know whether this patient has taken something to make him lose weight. So we have to always think of iatrogenic causes.
All right, awesome. So with kind of all those possible causes in mind, what are the key next couple of tests that you would say, let's definitely order for this patient?
Do you want me to answer, or do you want Dylan?
Yeah, that would be great. I know Dylan mentioned a couple of them, but just kind of what would your thoughts be in terms of like the order? How do you prioritize? Like, what is your definitive next step?
So definitely, I would definitely order the thyroid antibody, probably get a TPO, thyroid peroxidase, and the other thing I would always get in patients with hyperthyroidism and make sure that their adrenal gland is working. So I would get a random cortisol and make sure that they're not having an adrenal crisis on top of this, or they don't go into adrenal crisis as you treat the hyperthyroidism. So that's another thing that I would get.
Okay, awesome. So in the meantime, so we ordered all of those tests. What would you like to do? And Dylan, I'll have you start. Intervention-wise, anything you would like to do for this patient, and would you admit this patient, and what level of care?
So we definitely do need to treat them, because although the patient has been going on like this for a while and he doesn't appear to be too toxic, I'm not looking at the person. Based on his vitals, he doesn't look like he's going to decompensate immediately, but I do think we need to do the PTU, beta blocker, and steroids treatment to prevent him potentially kind of manifesting into a thyroid storm, which would be fatal for him, or could be fatal for him.
I think what Dylan has suggested would probably start a beta blocker and then maybe non-specific and start PTU, because we need to act, and then it will be a while before we get some more information, and I wouldn't be opposed to giving steroid like I suggested earlier.
And then the one other question I have is, with the fevers, would you or would you not start antibiotics? Dr. Abebe, I'll let you take this one.
I think, it doesn't harm early. If this was a patient that presented within the last 48 hours, I would probably do that. But he has already shown that he is able to maintain, his hemodynamics and so forth for the last 3 weeks. So I wouldn't probably, at this point, jump the gun and get an antibiotic started yet.
All right. So in terms of management, what we ended up doing, so we admitted him with telemetry, and then he was started on propranolol, 40 milligrams BID, which was used for symptom control. And we were able to maintain his heart rate at less than 90 with improvement of the palpitations on that dose. We ended up deferring the PTU until the etiology was more clear, and he was really well controlled on just the propranolol. So we ended up deferring the PTU in this particular instance. And just as kind of a note of that, those work by blocking new hormone synthesis, just as kind of like mechanism wise. And then we also deferred the steroids at this time because he had the fever and the mild leukocytosis. And so in the setting of not yet necessarily knowing his infectious or immune system, kind of status, we decided to wait on the steroids as well. But those, as also kind of a note, they would normally work to reduce the T4 to T3 conversion, and then also decrease an autoimmune process if there was something autoimmune going on causing this. And then also can help promote the vasomotor stability if this patient is hemodynamically unstable, especially if there was an adrenal component like Dr. Abebe was talking about. So several different mechanisms the steroids work with. And then the blood cultures came back negative, no growth to date. And we ended up giving him one quick dose of antibiotics at the beginning, but then his symptoms were really well controlled, and he was really stable. So he didn't get antibiotics after that one. In terms of the further workup for his thyrotoxicosis, so the thyrotropin receptor antibodies and the anti-TPO antibodies for Graves and Hashimoto's were both ordered, and those are pending. And then the thyroid ultrasound and RA radio iodine uptake scan were both obtained the next day. And so thyroid ultrasound just showed increased vascularity of the thyroid. There were no discrete nodules seen. And then the RAIU scan showed diminished 24-hour thyroid uptake of 0.1% and faint distribution of radionuclide throughout the thyroid gland. And then random cortisol was normal. So Dylan, I'll have you kind of go first with all this new information. So kind of what does all this new information tell us, and how do you kind of put everything together to make a diagnosis with all of this?
Okay, right. So again, we were choosing between whether we had a, toxic adenoma, potentially a multinodular goiter. We're looking at Graves, and then we're looking at either thyroiditis or potentially exogenous thyroid use. This kind of shows us that we didn't see any nodules, so we could kind of knock off a couple of those off of our differential there. And we also saw that it was low uptake and not high uptake from the iodine scan. So that kind of pushes me away from Graves and pushes me more towards a thyroiditis picture caused by potentially post-infection and autoimmune, some sort of cause there.
Awesome. Yeah. So, and kind of like the kind of big notes I took from this was with the RAIU scans, it really helps kind of divide different etiologies into etiologies that would have like an increased iodine uptake and ones that would have a decreased uptake. And so because he has a decreased uptake, that would leave us with things like the subacute thyroiditis, which would be like the de Quervain's, which is the painful one, painless thyroiditis, radiation induced if he had a history of radiation, excessive exogenous thyroid intake if he was taking excessive replacement therapy or just taking someone else's medication, things like that. Or rarely there can be causes of ectopic thyroid hormone production, like if you had a metastatic thyroid cancer or things like that. And then the etiologies that would have had the increased uptake, which is not what we're seeing, but that would make things like Graves, multinodular goiter, that sort of thing, that would make those more likely. Dr. Abebe, do you have anything to add in terms of kind of what we just talked about or the new information that we just got?
I think you guys discussed it so well. I don't think I have anything to add on this one. This was very comprehensive.
All right, awesome. So yeah, so just to kind of make sure it's really clear, so the most likely diagnosis that we decided we were working with at this point is the subacute de Quervain's thyroiditis, which is often thought to be a post-viral issue with him having the sore throat and the cough a couple of weeks ago. That's most likely what's going on. And so let's see, he's not experiencing any thyroid pain at all. It's just kind of that mild pain on palpation. So otherwise, so kind of with all this diagnosis, things that we're working with, does any of this change your management plan at all?
Now that we know that it's more likely to be the de Quervain thyroiditis, I'm not, an expert in this at all, but I would imagine that at this point we'd maybe want to think about giving the steroids. I know we had talked about holding it earlier, but I'm going to have to defer to Dr. Abebe here because I'm not really sure where we're going with this.
I think the way I see it, this is more of a temporary illness, I would say, because it's usually some viral. So I would say more of supportive therapy. And maybe at this point, since he's stable with what has already been done, I would probably not change anything at this point and probably have an endocrine follow-up for him. Because you would expect this to be a self-limited condition from what I remember.
And then we kind of talked about this a little bit, but didn't get super deep into it. But we talked a little bit at the beginning about, mentioned thyroid storm and how concerning that would be. So Dr. Abebe, would you mind telling us a little bit about just kind of what you would be looking out for that would suggest thyroid storm, what you would do to kind of assess risk in this patient and how you would manage that?
So I think, we talked about earlier some of the things that would, suggest a thyroid storm where, patient becomes very unstable, blood pressure may be low, and, they would be hyperparexic. You would expect it would be dehydrated, and lab may certainly show other findings, maybe hepatopathy with elevation in transaminases and alkaline phosphatase. Maybe patients may have signs and symptoms of heart failure. So I would be looking some end organ, I would rather say, or other organ involvement, in which case, we have to think of involving endocrinologist and giving steroids and maybe giving PTU / other antithyroid agents.
Awesome. So our patient has been really clinically stable, has been improving with that propranolol, so there isn't a concern for thyroid storm in him. So it's now hospital day 3 at this point, and heart rate is still well controlled on that propranolol, less than 90. The thyrotropin receptor antibodies, which were the Graves antibodies, came back negative, and the anti-TPO antibodies, which are those Hashimoto's antibodies, also came back negative. And since admission, he has still been having those nightly fevers up to 101 degrees, and has had a mildly elevated white count. It's been consistently kind of 13 to 15,000 range. I'm just hanging out around there. And those fevers, they've been starting in the early evening. They persist throughout the night, and they're associated with myalgias and diaphoresis. And he's been able to control that temperature with the acetaminophen and ibuprofen until the fever generally breaks on its own kind of mid-morning. And he says that this is the same pattern the fevers have been having for the last 3 weeks, like he mentioned, really no changes to that fever pattern. It's really what's been going on for the last few weeks. And just kind of as kind of a reminder of what we talked about towards the beginning of the case, he did see his PCP a few weeks ago for the fevers and didn't have an answer with some basic labs. And this admission, he has had a normal CMP, normal CBC with differential, other than that slightly elevated white count and slightly low hemoglobin. The normal UA, normal chest x-ray, negative blood cultures, negative COVID, normal procal. So all of that we already got on admission. So kind of with all of those things in mind, Dylan, I'll have you kind of answer first. Well, first of all, let's update the problem representation. So Dylan, would you mind kind of updating our summary of what's going on with the patient right now?
So just to recap, we had a 32-year-old male who came into the ED after 3 weeks of intermittent, mostly nightly fevers and tachycardia throughout the day. He had a little bit of cough, but that was pretty residual from an illness he had 3 weeks prior before all this started, where he had a sore throat. And since he got to the hospital, we have worked up the fact that he has some sort of a thyroiditis going on. However, even though we've had it stabilized on propranolol and we're not worried about him going into thyrotoxicosis, he is still having this nightly fever, this nightly sweating, and these nightly myalgias while he's still here with us. And so we're trying to work that up at this point.
Mm-hmm. Awesome. That was a great summary. And as kind of an additional term that you can use at this point, and there's several definitions actually kind of floating around, but the term fever of unknown origin is fever lasting at least 3 weeks with no source identified after 1 week of outpatient or 3 days of inpatient therapy. That was kind of a common one I saw online.
You know, the definition is pretty generic. And if you are hospitalized and you've been there for more than 3 days, I think, because most of the time, those are the kind of patients we reliably think of having as a fever of unknown origin.
So Dr. Abebe, would you mind giving us kind of, I know we talked a little bit about it in terms of fever differential at the beginning, but especially once it crosses into fever of unknown origin territory, what are kind of the main categories or types, like causes of etiologies of that fever that we might want to be thinking about?
I think the broad umbrella would still remain the same. Majority of the time in patients with fever of unknown origin, if I remember right, maybe around 60% of the time you may come up with the diagnosis, but the rest you may not come up with the diagnosis. That's the first point. Second point is you still think of the uncommon kind of infection. When I started, I said, knowing that he has had the fever for 3 weeks, we're not going to be thinking the common infection. So you would have to think granulomatous infections, and in fact, maybe endocarditis is another infection that I would be thinking about, but the granulomatous disorders would be high in the differential. You have to also think of HIV and rule HIV out in this patient. The other category still remains like malignancy, rheumatologic disorders would still be the 3 things that I would consider in a patient coming with fever of unknown origin. I mean, there are a whole host of conditions that you can go on, especially when it comes to the infectious etiologies. So you think of bacterial, viral, fungal, parasitic infections, and travel history would be very detrimental. What kind of job the patient has, kind of trying to branch out and see if we can come up other differentials.
Mm-hmm. All right, awesome. Yeah, so that was kind of one of the big things I learned from like working with this patient is a lot of fever of unknown origin. Like there's a few things that are important to rule out, but then also a lot of it is really dictated by getting a really, really solid in-depth history on the patient and then targeting it to like that patient's particular risk factors. And then another important thing Dr. Abebe mentioned, getting an HIV test and really assessing the immune status of the patient with the fever of unknown origin. So like making sure they don't have HIV or are on immunosuppressant drug, like they had a transplant or something like that. Or if they were neutropenic, on chemo, anything like that, that would make them immunocompromised, because that would really just kind of change how strongly we were pursuing different opportunistic infections and how strongly we would need to kind of look at some of those. So those were a couple of the kind of really important points that I learned from, kind of working up this patient. We ended up consulting ID and rheumatology both for the workup of this patient. On a more extensive history, I won't get into like the super specifics of it, but as kind of a summary, it did involve a little bit of remote travel history, some animal exposure, and then he did have a mild rash that kind of all of those features helped kind of direct our workup for this patient. And the rash ended up being biopsied and was just a common eczema, so it wasn't anything infectious with that. But I will read off some of kind of the things that we got. But Dr. Abebe, is there anything that you would say, this is a test we absolutely 100% need to order on this patient, make sure we're not missing anything?
I think depending on where he's gotten, I think when you tell me travel history, I'd be thinking of the chikungunya virus, Zika virus, dengue virus. Although these are hemorrhagic fevers that would definitely would manifest with some sort of coagulopathy, but which he doesn't. The other things I would be thinking would be leptospirosis, brucellosis, especially if he has animal exposures. Tularemia is another thing that I would be thinking about, and if he had obviously a travel history with chronic exposure, you would be thinking of chronic granulomatous disorders, including tuberculosis, although that would probably be low on my list.
Mm-hmm. All right. And then Dylan, do you have any extra tests that you would say that you kind of thought of off the top of your head, or things that you would like to order on him?
No, I agreed with most of it. I do think we need to look at those, abnormal bugs that cause like gram-negative endocarditis, like Coxiella. I agree with most of those. I don't really have anything else to add. Just that since his travel history was over a year ago, I don't know if some of those you mentioned were ones that you would have expected to see earlier, and if we could maybe like reduce the amount of tests, I guess, based on that. But that was my only thought.
Awesome. So I'll kind of go by different consultants categories. So from an infectious disease standpoint, he was normal or negative for all of the tests that we ordered. So negative for HIV, negative EBV, CMV, Hep B and C, negative tuberculosis, negative malaria blood smear, negative RMSF, Lyme, toxo, crypto, Q fever, leptospirosis, brucellosis, tularemia, and echo was negative for endocarditis. So that whole infectious workup, everything was negative. And then from a room/ID standpoint, ESR and CRP both came back elevated. And then otherwise, the rheumatology workup was also negative. So that included negative RF, ANA, CCP, MPO, PR3 with reflex ANCA. And then we even obtained a CTA of the chest, abdomen, pelvis to look for any signs of large vessel vasculitis, which also came back normal. And then from kind of looking at a malignancy or other miscellaneous causes standpoint, again, essentially everything came back negative. So normal peripheral smear, normal CT chest, abdomen, pelvis, didn't show lymphadenopathy, masses, or abscesses. Immunofixation was negative for paraprotein. And the only thing that came back abnormal on it was the SPEP was consistent with acute phase response. So not any, nothing specific there, but was just showing along with the ESR CRP, like there's something inflammatory going on, but, it really didn't point us in any direction in terms of, a cause or diagnosis. we looked into some case reports. There were some very rare case reports of fever of unknown origin being the presenting symptom for thyrotoxicosis. They were mostly in kind of elderly patients, but there were some case reports of that. But managing a thyrotoxicosis didn't do anything for the fever. So we thought unlikely, but a maybe. So all of that, only abnormals were just kind of inflammation, ESR, CRP, and SPEP consistent with acute phase response. So for this particular patient, essentially there was a really extensive discussion with all the consultants, and the decision was made to just send him home on a steroid taper since his pattern of fever seemed consistent with a rheumatologic cause. The nightly fevers go away in the morning, and then the lab evidence of inflammation, and then ID after a really, really extensive workup, they were confident that it wasn't an infectious cause. And so they said, let's try a steroid taper and see how that works. So they sent him home with that. And so there was no official diagnosis. It really ended up being a fever of unknown origin that he was sent out with, which is oftentimes, I think, really hard for us to accept, like not giving them, this is the answer, this is the definitive treatment. And like Dr. Abebe was mentioning, sometimes there can be as many as 50% of fever of unknown origin cases that just don't end up having a diagnosis. But the good news with that is that the prognosis, if you don't come across a diagnosis, is really great. So once you've ruled out malignancy, ruled out a lot of those scary things, it has a really good prognosis moving forward, even though it's really hard to say, hey, we don't have an answer for you. And so Dr. Abebe, I was wondering if you had any kind of like advice or words of wisdom in terms of, how do you handle balancing these patients, how aggressively you pursue finding a diagnosis versus just kind of saying, I think everything, I think things are gonna be okay, let's just continue to monitor you. How do you balance those?
I think first I want to apologize. Earlier on, I gave you a very mistaken kind of path. I was thinking hyperparathyroidism in my mind. As I was talking, it didn't make sense. So I kind of quickly directed myself into saying causes of hyperthyroidism. So I apologize for the wrong direction I took you, but the differential diagnosis remained as I discussed earlier. But as you rightly said, it's kind of difficult to not give diagnosis to patients. But I think the way I look at it is, I always tell my patients that you have had this fever for a certain amount of time. We've done all the tests that we can. The best thing in such scenarios is actually to follow as an outpatient with all the consultants and rush into doing things that are unnecessary from a standpoint of harming the patient and financially. I would have a saying in steroids. I think you have to be very careful in initiating steroids without having a diagnosis, just because you have a feel, maybe it's a rheumatologic disorder. That's going to be a slippery slope that you're going to have difficult time coming off. Although, we always say, rheumatology colleagues, it was like, why don't you throw steroids and everything would get better. I think many of the rheumatologists would tell you, giving steroids just to see how he does is usually not a good idea. So if you have to learn something, I would say avoid using steroid as a means of relieving symptoms without having a good path. In the current situation, I understand that they wanted to see if that is going to give him some relief, but I would have real hard time going with that path, in my honest opinion, without having diagnosis, because there are a lot of other things that could be, even in infection and rheumatic disorders, or even malignancy, that we may not have uncovered yet. So it would be a difficult decision.
Thank you so much for that. Yeah, so that was essentially what you were saying. Follow-up outpatient is really key. And that was our plan with this patient, was just we sent him home and set up several appointments to follow up outpatient with the people he'd been consulting with, and ensure that we were kind of following and making sure we weren't missing anything from there. So that is really kind of the end of that case. So Dylan, do you want to share with us just kind of one or two key takeaways that you had from this session in terms of like something you learned or a key point that you're going to kind of carry forward?
Yeah, for me, I guess I had heard the term fever of unknown origin, but I hadn't really done much with it at all, or looked up much about it at all. I think it's good to know that, yes, when we have this fever of unknown origin, we can look at, the most common causes are ID, autoimmune, malignancy. But I like Dr. Abebe's last point there about, if we can't figure out exactly what's going on and it doesn't seem like this person's at any risk of like acute decompensation, then at what point, is it okay to just like send them home and not have medical waste or even harm them? So I think that's a good point, is that you don't always have to just chase something if it doesn't look there's an end in mean.
And one big thing too that I kind of learned with this was the importance of just kind of communication with the patients, because I think we could have been more or less aggressive in terms of pursuing a diagnosis or trying to, do something about it, depending on the patient's preference. They were, he was stable, probably ready to go home if he'd wanted, but really wanted to kind of figure this out and get the workup more inpatient. So a lot of it was just kind of based on communication with the patient and their preferences, what they were willing to do kind of in terms of their time and financially in order to kind of pursue it. So
I think first I must say this was an excellent case, very educational. I think what I would say is this probably highlights the fact that if you have fever, although from 1 to 6, it may be infection, you have to remember the other 4, meaning, you think of infection, then you have to also remember the other etiologies that we talked about. The other thing is clinically, is the patient clinically stable enough, or do we have time to pursue further tests before we act? It sounds to me if the patient has had fever for some time, it's just not the regular cause of infection, so we have to look beyond that. And the third point that I'm going to make in regards to fever of unknown origin, if you're not able to find out the cause, follow-up is the way to go, although patients may not be happy going home without a diagnosis.
All right, awesome. Well, thank you, Dylan. Thank you, Dr. Abebe, so much for being discussants with us. I learned a ton from going through this case again with all of you, so I really appreciate it. And we'll see you guys next time.